Hello, everyone. This is Justin Jeffers. I am assistant professor at Johns Hopkins University, and I'm also the co-chair of the Education Committee, which is sponsoring today's webinar. Thank you for joining us. And for those of you that are not IPSS members, we all encourage you to please consider joining. It will allow us to support and continue to do webinars such as this, as well as lots of other member activities that in my opinion, are worthwhile. So please take a look at the website. It's ipssglobal.org to see the many benefits that membership can offer. And a few quick housekeeping notes before we get started today. If you notice on the right-hand side is your control panel, and about 2/3 down, there's an arrow, a tab for questions. If you open that tab, there's a box where you can type in questions, and we will do our best to answer them during the webinar, but worst case, we will get to the questions at the end of the presentation. Today, Trish Wood, Carrie Appleton, Joe Hagerty, and Suzanne Nelson will be discussing Hot Debrief. Is it more than a conversation amongst peers? They will be highlighting the establishment of acute clinical review processes in their hospitals. The discussion will include quality and safety, emotional and well-being, and successes and challenges. And I will turn it over to our presenters, starting with Joe, and allow them to introduce themselves and get started with their presentation.
Hi, everyone. My name is Joe Hegarty. I'm a neonatologist in Starship Children's Hospital in Auckland, a member of the Starship Simulation Program and Board of Directors for IPSS. It's my pleasure to be here today.
Hi, and my name's Trish Wood. I'm the operations manager for the Starship Simulation Program, and I've spent many years as a nurse working predominantly in the Children's Emergency Department in Starship Children's Hospital. And I have been involved with IPSS for many years and am a member of the Education Committee.
Hi, this is Carrie Appleton. I'm a clinical education specialist at Children's Minnesota. I'm a newer member to IPSS, but I went to their conference once and had to join because it was so amazing. So it's a pleasure to be with you guys here today.
And I am Suzanne Nelson. I am a simulation education specialist with Children's Minnesota. Before I had this position, I worked as a pediatric emergency department nurse. I also have a pediatric clinical nurse specialist degree, and I am also a IPSS fellow. So I'm really excited to present some of this work today.
Great. So I think we're going to get straight into the overview now. Thank you. So we met, Trish and I attended Boston 2017 and met Carrie and Suzanne at that conference, the IPSSW workshops and symposia. And we had a conversation at that stage about some of the work that both our teams were doing on Hot Debrief, and then met again at the next IPSSW in Amsterdam in 2018. And at that point really agreed that we wanted to share some of the experiences we'd had in developing our programs and the content, and seek some wider feedback, as well as sharing our tips for success and some of our challenges. And we finally managed to get to do the webinar now. So we're going to talk from both sides of the teams. You'll hear us switching between presenters as we talk about both the Minnesota and the Starship view on Hot Debrief. Thanks. Next slide.
Okay, a little bit about the development of our project at Children's Minnesota. Really, it had its roots planted in 2015 when Carrie and a couple of her colleagues attended a trauma conference, and staff shared some pretty personal and raw reactions about some of the things that they had been dealing with in the workplace. And it was really a call to action for us. And that's where we started in, I want to say, 2016, and we created a partnership between myself and simulation ethics and nursing education. And this partnership developed, and we developed a pilot study and some data collection around that. We rolled out the pilot study on our PICU at our Minneapolis campus. We're a 2-campus hospital, and we collected data about workplace burnout. And then the intervention of debriefing was on the PICU was quite successful. It became quite a powerful thing that people really connected with. So we soon found ourselves getting requests for training on other units. And right now we're training charge nurses, and we're currently implementing some pre and post survey questions that relate to employee wellness. And we'll get into more of some of these details as we get into the webinar, but this is just an overview of how we developed our particular project.
And it's Trish here. I'll tell you what was our driving forces at Starship to get this going. You know, post the Boston conference in 2017, we attended a workshop that was included both some of the work done at CHOP, Children's Hospital of Philadelphia, and Texas Children's. And we were quite impressed by the workshop. It answered a lot of questions that our clinical teams have been asking for. They were saying that, you know, you guys are debriefing simulation, can you debrief these real events? And so from that was our impetus to get going. And so we developed a working group, had plenty of meetings, made plenty of plans, revised those plans constantly until we had a workable resource, rolled it out in a sort of soft sort of manner rather than a hard manner, and put in some feedback loops so we could report on what we'd done and evaluate the effectiveness. Next slide.
So there is quite a substantial amount of evidence about hot debrief. And just to clarify for the conversation we're having, hot debrief essentially means debriefing a clinical event within a short time frame after the event happened. And so that time frame can vary depending upon your definition, but for us it certainly means quite an immediate afterwards. And looking at the literature, there's increasing support now for using clinical debriefing and shortly after the event. There's the potential for improvement in patient safety, quality improvement. There's also a potential improvement for staff well-being because you have an increased recognition of the things that happened and a better knowledge retention of that, and less dampening down of things that you will potentially ignore if you debrief at a much time displaced from the actual acute event. And in fact, many of our international bodies are now recommending post-resuscitation debriefing for clinical practice performance improvement. And one of the really interesting things for us to find was that the scripted standard script used for debriefing facilitates this, because what was happening in our hospital was a very much ad hoc debriefing by people who felt they had the experience and the ability and the passion to do that, but without any framework to do that. And so that was something for us that really drove us to develop the hot debrief tool within Starship. Next slide, please. Oh, and click again. Oh, maybe click a couple of times. Sorry, these all seem to be animated. Thank you. So there's a lot of evidence out there that supports hot debrief, but one of the challenges that we had at Starship was concerns within some of our psychological support team and our psychiatry team about the impact of debriefing on well-being. They had concerns based on some of the psychological evidence, particularly from a military and trauma background, that debriefing immediately after an event with the focus on psychological debriefing actually had some potential negative impact. And so this was very interesting when we were working in our teams across a number of different disciplines to manage the expectations of what people wanted from debrief and how to do that in a very safe manner. And particularly then when we met Stan and Kerry, our interest was particularly piqued because we'd had that experience within our team of some of the concerns, to hear the really positive work that they were doing with their debriefing and the different focus to ours. All these references are available in our reference lists. Next slide.
All right, so this slide just shows some of the differences that we Sorry, that's you.
That's okay. I'm having Wi-Fi issues. So
Okay.
All right. I think one of the bigger things, differences with the Children's Minnesota program is that we really are very intentional about the use of human reactions. We use this term because we're trying to create a space for participants to share not only their emotional reactions to an event, but also cognitive reactions, physical and behavioral. So it's not just feelings. You know, human beings experience lots of different things during and after a critical incident, and we want to make sure that we are framing up a safe space for people to be able to share all of those things. Our debrief is structured in 3 phases, and our facilitators are all trained. We don't just hand this tool out and allow people to use it without going to our training, which is a 4-hour class. We don't keep formal notes, so what's said in the debrief stays in the debrief. Managers can certainly ask about attendance and how well it was received, but that's generally all that's shared. And there's no current written record either.
And for the Starship differences, we had a very big focus on quality and safe care. And we were very driven by the fact that we wanted it to be a non-emotional debrief. We almost felt that it was easier to just look at the care that was provided, the systems and equipment and resources used, and were they sufficient for staff to support them in a critical situation. We wanted to have a very structured guide, and we actually spent some time working with one of the psychologists to script some sections so that what was saying for the novice that was using the running a debrief was safe, and the language used wasn't going to hurt people. We've made it so that training isn't an essential requirement, that people can pick up a resource, it has a guide that goes with it, and just do that. But we did actually run some workshops to support people when they started to use that. We wanted to also capture what was happening, so we built in some reporting processes both locally in the area where the event had occurred and organisationally, so it was fed up through existing processes so that we could make some impact on quality improvement. And then there was the opportunity to capture documentation, especially in the early stages. And I think looking forward, we may actually be able to run these meetings and not have any documentation and still get the good catches and the things that we want to change actually recognised and improved through just this existing framework that's available. Next slide, please.
So I'm just going to discuss really briefly some of the reporting loops that we have here at Children's Minnesota. And really our trained facilitators serve as a front line of our reporting loop. And part of our training, like Carrie mentioned previously, is we include some pretty specific training on what are the resources available so we can hook employees into appropriate resources if that's what's needed after a critical incident. Our unit managers are also included in this process, both to help support individual needs and facilitate larger debriefs if they're requested. And then we have our employee assistance program, which is for either groups or for individuals, and that reporting is anonymous through that data is not reported out to us, but they are allowed to use that as a reporting loop as well.
And at Starship, when we document a case, a copy of that is left with the local lead for the area, the nurse unit manager or the service clinical director, and they can highlight the systems in the process. And in doing that, we wanted to be really clear that there was going to be no identifying patient information on that document. So I suppose that's the big difference in our team between the 2 centres that are using that. Next slide, please.
Okay, so at Children's Minnesota, we did run a pilot study back in 2016. We started by trying to measure the prevalence of moral distress and burnout among staff. We had lots of anecdotal evidence, and so we chose to combine 2 validated tools to collect our evidence. And we had a 41% response rate from this survey. We did survey both PICU staffs from each of the campuses. Next slide, please. The survey was a total of 28 questions, which also included some demographic questions, and there are some sample questions here for you guys to review also. What was really interesting, though, is that 100% of respondents all reported some level of moral distress and burnout. So we knew we were on the right path, that there definitely was something going on that we needed to do more about. Next slide.
So in Starship Children's, we undertook a needs analysis of our hospital staff prior to beginning any work on the Hot Debrief tool. We knew that it was already happening informally because people were telling us that and asking for more training and more experience. But we found that from our survey that in fact the whole team wasn't always present. People tended to continue to debrief in silos. Medical would continue with their workload and talk later. Nursing staff would often talk as they were clearing up post-event. And we were missing a lot of the information that was going to be useful for us to improve the patient care, the team working, when people weren't able to get that conversation together and discussion together. There wasn't a standardized structure, and so although people who had experience in debriefing and simulation or had a passion for discussion and support of their own teams were leading debriefs, people were struggling to know quite how to get the conversation going and how to guide people and how to bring it to a close. And so we thought this was going to be really useful for us to develop something standardized for people to use. We also were keen to keep it to a very short period of time based on the fact that people were struggling to do the whole debrief conversation at all. Next slide, please. So, next slide, thank you. So following our survey of the staff, we got together as a working group and developed over a number of iterations, and based on the work of CHOP and Texas, as Trish has mentioned, what we've called our after critical event review. Hot debrief was felt to be a terminology by some members of staff that had negative connotations, and therefore we had to come up with a different title. And we've decided upon this one. I think probably informally we still often call it Hot Debrief. But the purpose of this document, and this slide and the next slide will show you the two slides of a one sheet of paper, are for people who have either attended our training, which we ran workshops for using simulation of a debrief of a clinical event after they'd watched a video of a simulated clinical event, to take that tool and use it in their clinical areas. And also for people who'd not been able to attend a training but felt that they had some additional skills and were interested in it, to be able to take the tool and do it without training. And we really wanted to make this as feasible and possible for people to use and simple. So we tried to sort of script quite a lot of it so that people had the option to use that if they felt necessary. We've also used it in a number of our crisis resource management training, our teamwork training sessions. So when we do a scenario in situ normally, we've then had our debrief of the scenario, and then we've had a debrief with the team of the clinical event as it was. And we're getting feedback continually that this is helpful for people to use. So you can see that our focus is very much on the non-emotional side, but people do talk about that. And I think as teams performing healthcare, looking after patients, we want to talk about the emotional impact as well. And so in fact, although our focus was not on emotions, we have still had discussion about that, and we've not stopped people having discussion about that. And when we did our redo survey at the start of this year, we continue to get feedback that, that people are finding it useful for emotional as well as for quality improvement. At the bottom of that slide, you can see our documentation and feedback loops. So the documentation goes to the charge nurse Trish mentioned. We ask people to document good catches. So if there was something that prevented an issue getting to a patient and a risk, we use the DATEX system in our hospital. And then we also have some recognition for additional support, recognized being required within the team members and how that's accessed. This doesn't go into the patient notes, and that was a big discussion that we had when we were starting it up. And so as you can see, there's no patient identifiers on the record anywhere. Next slide, please. So some of the important clinical outcomes that we've had, we looked at them across processes and equipment and resources. We found that within our team, our teams across the hospital, there were a number of things that really highlighted change that we felt perhaps wouldn't have been highlighted if they hadn't had an immediate post-clinical event discussion, things that potentially people would have minimized and ignored and said, oh, well, that happens anyway all the time. And so there's a list of some of those processes that, and equipment resource problems that we've identified. I think one of the most interesting ones was the recognition of the massive transfusion protocol and a review of the timing of the delivery of the boxes, the content of the boxes, and the process to cease that whenever they were no longer required. People weren't familiar with that high risk, low frequency event. And yet debriefing the actual real life clinical event led us then to go on and do some simulations where we simulated MTPs and continue to improve that process within our hospital. And as you can see from the diagram on the right, this is something that's been rolled out and taken up across many services. So we're very excited to see the passion that people have had and the desire to use that. And compared to our initial use, it's a much wider spread across our hospital. Next slide, please.
Okay, so a little bit more about the implementation of our project at Children's Minnesota. The stress debriefing is really the critical incident stress management concept of diffusion, which we renamed for our training because we just didn't feel like that particular term really resonated with us. And in turn, we developed a working definition of distress debriefing, and that we're calling it a debriefing format that focuses on the human responses to a critical incident. And below on the slide are some of our guidelines for when a distress debriefing should be held. It's held at the discretion of staff. It doesn't have to necessarily be a resuscitation. Oftentimes these are being used after some behavioral codes that have occurred. We really are leaving it up to staff if they feel like they need to have a conversation about a particular incident. And like Starship, we really want to capitalize on getting this conducted before the end of the shift, so people have a chance to process what they've just experienced and decide if they do need further debrief on a particular incident. And that we limit it to staff with direct contact during the incident. That way we hopefully avoid some of the judgment of others who weren't actually in the situation. And ideally, we like to keep this short, being mindful that these are people that are working, have busy shifts, that we want to still provide that space, but just provide a short time frame, about 10 to 20 minutes. Next slide. So a little bit about our training and how we developed this at Children's Minnesota. We chose the charge nurse role mostly because Carrie and I are nurses and it just seemed logical. But typically a charge nurse is really aware of what's occurring on their unit, and then they have the leadership capabilities to really gather folks for a debrief. And since Carrie and I are nurses, we thought that this would be the best route to start with training. So we do require those that are going to be trained in this technique to attend a 4-hour workshop where the first couple of hours is some didactic content, understanding this debriefing concept, and then we do some practice. And then along with that, we review a lot of our employee assistance program resources so people understand what they can hook employees into if they need more resources. In addition, each unit is given a resource manual to refer to when they're debriefing, meaning we've got some resources in there. We keep our slides in there so they can refer to those as they need to as they're conducting these debriefings. And we've also created a badge, an ID badge size reference guide that staff can use to just read from so they don't feel like they have to go in without a script. Next slide.
All right, so a little bit more about what distress debriefing looks like at Children's Minnesota. I'm going to just talk about these phases briefly quick, and then we have a short video that we'll share. So you'll notice that there are 3 phases. The first and the third, it's really the facilitator doing all of the talking, whereas in the second phase, the facilitator is putting out some questions for people to contribute to and making sure the conversation stays on track and doesn't derail. So during the introduction phase, the facilitator helps to set the stage, helps people new to this type of debriefing to understand what this is and what this isn't. This is not a problem-solving session. This is a space for people to gather more information and share their experience. It's also important for the facilitator to create a sense of psychological safety within the space they've chosen to conduct this and make sure that everyone's really clear about the ground rules. what's happened here stays here. People's stories are their own. We ask people not to share other people's stories. During phase 2 with the exploration, the facilitator is really asking the group 2 questions. They're wanting the group to chronologically put the event back together, so to add each individual piece, which really is helpful for people as they leave the event to see from alternative lenses, because we all are very fixated on what our role was and what we did, and we don't always fully understand other people's contributions. During this time, the facilitator will then also ask, how are people doing at this time? And the word doing might sound really strange, but we wanted to avoid using the word how are people feeling, because we're trying to, again, get at those human reactions and not just the emotional components. And then in the last phase, the information phase, the facilitator will do a brief summary of the debrief, work to help validate participants' reactions, and make sure that people are clear on what are the other resources that are available to them. So this is a very low budget video clip that Suzanne and I created to use during our training to help our attendees understand or visualize a little bit better what we were asking them to do. So we'll just watch the first 50 seconds. Oh, I should say, hold on. Well, while this is teeing up, this was a debrief of a behavioral code. And so this is a team that's come together after this code to discuss the event. Is it working? Because it doesn't seem to be working on my end.
No, it's very slow.
And there's no sound.
Okay. Okay, let's just maybe not play the video. I look amazing, but we'll go past it.
You do.
So, we wanted to put that in there just because we thought it could be helpful for you on the line to just be able to visualize again a little bit more what we're talking about, but another time. Next slide, here we are.
Suzanne.
Oh,
Suzanne.
Oh, sorry. So some of the outcomes, I'll just say too that some of our outcomes, it's tricky because we're doing a debriefing where we don't record anything, we're not documenting anything. So really, what are we wanting participants to walk away with? And we want them to leave the debrief with mental facts of the event. Sometimes you're walking into event mid-event, and it helps create that full picture so people can walk away knowing what actually happened in a situation, that we're normalizing and validating people's reactions. Knowing that one of your peers feels stressed as you are is really validating and helpful, especially for our newer nurses, knowing that they're not alone in realizing that some of the situations that we were put in as nurses are difficult. We do have some evaluation data that we ask our facilitators to fill out, and just really what we've all asked them to do is to say what the event was, who attended, and just so we can keep track of how many are occurring, but no other data. And what we're finding is that people are reporting very positive aspects of teamwork, and really the ability to have a space to sit and talk for a few moments and catch your breath before heading back to your work has been really valuable. And then a little bit about our implementation in our pre and post survey questions is what we're trying to do is gather some more data on whether or not this type of intervention is impacting our employee wellness. And we're trying to see if some of this stuff, and this will be coming up in future, where we can see if this type of intervention is truly helping our employees feel good about coming to work, feeling that they're supported at work, and they continue to stay with us at Children's.
So this is just a visual visual representation of wellness support at Children's Minnesota. We'll start at the bottom of that Tier 1 orange section, and this really is something that I think every hospital has. We are, as teams, we're having conversations all the time after difficult or challenging events happen within our units, but really wanted to just remind or call out to, what does this support look like? So these are our peers, our managers, our spiritual care department, and our social work department, who are definitely trained in similar types of debriefing methodologies as well. Tier 2 is that next level, and that's where distress debriefing fits in. And distress debriefing is really for teams. It's for the team that rushed to save the child. It's now a chance for the team to come together to help themselves. Peer-to-peer is a newer program at Children's Minnesota that we've adapted some principles from Children's National, and Nationwide Children's. And those are more one-on-one interactions. And then our Tier 3 is more of what's outsourced from children. So things that we're not exactly handling ourselves firsthand, but working through our health benefits policy or programs. Next slide.
Okay, a little bit about some of our Children's Minnesota, about what has worked for us as we've started on this journey. Initially, we had a lot of requests for training once we started this pilot, and we've got a lot of requests, and it's dwindled a little bit because, well, we've trained a lot of people. I think we're up to now, Carrie, what are we up to? 140?
At 135.
135. So we've trained 135 charge nurses at this point. And also, along with that individual invitation, so meaning we're talking to individual people to invite them to training, but we're also, when we're inviting people to our debrief itself, that we're really taking the time to individually ask people rather than gathering people in a group. They have found that that's a little bit more successful in getting buy-in and individual buy-in. Management buy-in is absolutely key in this. We are lucky we have great leadership that has really fostered this and encouraged this and given this outlet to continue this work. In retrospect, we would have pulled them in a little bit sooner as the cart got a little, as soon as we started doing all this training, it got big a little bit quicker than we anticipated. So we had to do a little bit of backtracking, but overall, that has been really helpful and very valuable in how this has maintained its success. Making sure that our training is adequate for facilitators, and we're constantly looking at new literature that's out there, looking at our training, is it sufficient? What do we need to add for facilitators to continue that support? And then what are we providing for our facilitators' ongoing continued support? So where can Carrie and I insert ourselves to help ensure that the facilitators feel comfortable doing these debriefings, that we can help them practice? And something that Carrie and I have done too, is as well as helping with the training, is that we've visited units to explain the training, to explain kind of what our goals are and what the objectives are for this particular type of debriefing, so people understand when a charge nurse asks them, they know what that actually means. And timing and time is always a challenge for this type of work. And do you make time for this? How do you make time for this? This is really a culture change, and it can be slow, and we've seen quite a bit of progress in the last couple of years. And as long as we are seeing that units find value in this, that it's being done. And the more that we can reiterate that value, the more successful it's become. Next slide.
No, hang on.
Oh, no, I'm sorry, Trish. I'm getting ahead of myself.
Yeah. One of the key things with Starship was that our staff often came away from these events saying, was there anything else that I could have or should have done? And so one of the key components of our structured debrief was to add the medical facts in there, because we found that if people who may have been in and out of the room during an event had didn't have a full understanding of what was happening, they may have left with lots of questions and uncertainty. And so we emphasised including the medical facts to make sure that everybody was on the same page, give them all the same understanding, and that in itself relieved a lot of anxiety for all staff involved. One of the other key things that we did was we followed the lead from Stuart Rose and Adam Cheng, an article that they published in 2018 about charge nurse facilitated clinical debriefing in the EDs in Calgary. They did that across 3 universities, and we have also found that if this is led by the charge nurse, as Children's Minnesota have said, that it seems to work better. We find that our medical colleagues sometimes don't have the capacity after a big event to actually have to then facilitate and lead a meeting. So we've found a nurse leader is easier to be able to make these events happen, these reviews happen, and also they have the ability to pull the team together and to cover the clinical demands as well, and just to make that happen for a short period of time. So it's important to keep it short, and we said 10 minutes. Sometimes it stretches on a little bit longer in the hot debrief session, but we try and keep it to the 10 minutes. And I think the data showed that it was averaging 12, so we weren't doing too badly there. Another thing that we've done is, I know that Children's Minnesota have kept some resources for people to use in a folder and things, but we've stored our documents on our website for easy access, and we've also developed a guide which is a how-to for an ACE facilitator, because it may be some intervals between use of using the ACE debriefing tool, and we wanted to support that person so that this could happen 24/7, because we didn't want it to have to wait until the next morning when somebody was there, or if it was a weekend. It's then not a hot debrief. So it had to be something that could be picked up and used by any member of staff anytime, and to make sure that people could express their concerns and review the care, the clinical care that was given, and was there anything that was impeding it. And also to recognise the great job that our teams do on a daily basis. Next slide.
So that's us. I think we've done enough talking now. We're hoping that some of the people attending might have some questions or comments or feedback for us. We were really keen to leave a substantial amount of time for discussion, because we knew when we get together and start discussing it, we could spend hours. And we were keen to hear what other people were doing as well, if they all had experience of hot debrief in their services.
So this is Justin again. First of all, thank you for the presentation. Unfortunately, we won't. The people listening won't be able to turn on their sounds. We can't have a discussion in that sense. But there are lots of questions, and so I will kind of get to those. The first one from Stuart. So first and foremost, at the end, he says thanks for the shout out. So his first. And I believe it was a slide just before you guys presented the ACE form. There was a 100% something or other, and was just wondering if you could talk a little bit more about whatever that point was.
I think that's Carrie, if you want to talk a little bit more.
Yeah. Sure. That was in response to the survey so the combined survey on moral distress and burnout. So it was 100% of the people that responded to our survey had some level, and the tools leveled it out 1 through 5. So with, I believe, 1 being none, 5 being extreme amount, that it was reported amongst everyone who responded that they had some level of moral distress and burnout. So that just seemed pretty powerful to us to be able to see it that clearly, that this was really touching everyone in these 2 particular units.
So just to kind of follow up on that, I certainly see that in my space and really any intensive care or critical care space I've been in. But what was do you happen to know the response rate?
I don't have those numbers in front of me. We did publish this pilot study, and I'm not sure, Suzanne, did you include that reference in the last reference
It should be
page?
it's on our reference slide. That's the one that's in extremely tiny font because I couldn't fit. But it was published in the Advanced Critical Care Journal for Advanced Practice Critical Care Nurses. And that breaks down the data a little bit more as far as how many people scored 2 versus 5. I don't recall there being a lot of 5s, if I remember correctly.
No.
Carrie, please.
No, I think probably 5. I think there were 5 people.
Okay.
Yeah. But really, so it really showed that all of the people that responded showed at least some response to some of the questions like that we gave in the example, meaning things that were they didn't want to come to work, they didn't feel supported at work, that type of thing.
It's definitely very interesting and definitely a real problem.
Yeah.
In our world. So Terry Lister has a few questions, and I think it speaks to I think an issue that everybody in simulation and debriefing deals with. And the first one is just buy-in, and how are you guys? And you guys gave a few tips at the end, but talking about how to engage the staff to participate. And I think for me personally, it's always a challenge post the event in a busy clinical space, and and for me, even somebody who knows the value of this, it can be challenging. So I wonder if you guys could just, and Terry's wondering if you could just talk a little bit about that.
I can speak to it from a Starship perspective. We try to encourage as many people that were involved in the event to attend a meeting afterwards, and that can be challenging if the patient still remains in that area. It's probably easier if they've been transferred to the PICU or the OR or something, but then you don't have the whole team because some of the team that attended the event are still involved in the clinical care. But those that are available to attend the meeting are supported to do that. And for us, they don't actually need to speak. Just their presence and their understanding of the medical events is often enough, and then they'll continue to process that in their own time. Our clinical psychologists said that, and the evidence I think also supports the fact that if you make somebody speak after an event like this about their feelings, that it can do harm. And certainly some of the research that we've looked at also says that. So we are more than happy if people want to just sit there and absorb what's happening and not be an active participant in the conversation.
Yep. This is Carrie from Children's Minnesota. I would 100% agree with what Trish was sharing. And in our debrief as well, it's volunteer. You have to voluntarily attend, and you don't have to speak as well, because that's so important. The other thing that Suzanne and I have done that's been helpful is we found that it's not enough to just train people to be able to facilitate these debriefings, but that we have to provide some education to the user to help people to understand what is this and why would it be helpful for me. So planting some seeds for people to consider attending one, or even asking that one be held after an event that they were a part of.
Terry Lister has a question, and I can certainly relate to this. So as a debriefer, how do you remain calm and organized? I find with increased energy in the room, I think alluding to often there's increased energy, and that can make a challenge. And I think for me personally, just to add on to that, being the debriefer, I'm often the one that was involved in the event as well, which presents its own kind of sets of challenges. But if you could just speak to how to kind of bring the energy down to have a meaningful conversation.
So I think within Starship, one of the ways that we've managed that is by encouraging our senior nurses involved to lead the conversation. And for the majority of time, they will have had a role in that situation, and so they will also potentially be emotionally involved and already in a sort of high stress level potentially. But we found that, and we felt that having the person who was more likely to be the event manager, because in our situation that's more likely to be a medical person, lead the debrief as well. Actually, we were missing out on some of the key content, or there was a risk of missing out on some of that key content. And invariably, sometimes it does fall to the event manager to lead the debrief. But I think the people who will self-select into that situation are probably the people who have more experience of debriefing, particularly within the simulation field. I guess the other thing, Trish just nudged me here, is that food and coffee goes a long way to keeping people de-stressed and debriefed and calm. So, you know, making sure that when you have that debriefing meeting that you've got a space where you can grab a cup of coffee to bring with you, or a snack also helps.
And I can speak to a little bit about what we've tried to talk about at Children's Minnesota, and I think it's much the same as, you know, oftentimes the charge nurses could potentially be in those situations, but not always. Having water, so hydration after a stressful event is always very important. We're trying to excrete all those stress hormones, and just allowing a space for people to just sit down and take a few deep breaths. And before we get started, often can let the air out of the balloon. It's really what I like in our debrief too, is we've got this big balloon that's blown up, and we want the debrief to just let the air out of the balloon. And the more that we can do that, and we do recognize that sometimes these nurses are going to be enmeshed in some of these critical events depending on what has occurred. And really, we've tried to be deliberate about brainstorming where is the best place to hold these. If it's a little bit away from the unit, can we get people to watch patients? Can we do that so people can take the time to get away so they don't feel that pull to go do other things if that's been taken care of?
This is Carrie. The only other...
Oh, sorry, go ahead.
No, go. Oh, I was just going to say, we also encourage facilitators, especially when they're newer to it, if they've been overly involved in this case, to have somebody co-facilitate with them. So they're not leading the debrief on their own. They're maybe doing it in a pair, which can be a little less intimidating as well, to just know that there's someone there who's going to support you and help this process go as best as possible.
Yeah. And so that really, that leads very nicely into what I was about to say, which is within the neonatal intensive care unit, one of the things I found myself often doing is actually then debriefing the debriefer who's led that debrief, having a conversation afterwards to check in with them that they were okay, you know, in a kind of, how did they, I guess, very simple plus delta model, how did they feel that went, and, you know, what would they change next time, and giving some similar kind of, I guess, coaching and feedback on the debriefing of the event. And I think that's something that's really helpful. We all seek to do that within our simulation team, and therefore I feel we should be supporting that within the clinical environment as well.
Great. Tara's another question. When you say what happens here stays here, how do you take areas that need improvement and provide education at a later date?
Is that more to Minnesota or is that to Starship?
I think it was Minnesota that made the comments.
Yeah, I think so. Okay, checking.
Suzanne, do you want me to take it or you want to take it?
We can both talk to it. I can start though. I think so. Really, we don't really do any sort of documentation, and the questions that we ask within the distress debriefing aren't really questions where, you know, if something were to occur, the goal is to try to keep the conversation really based on kind of sequence of events rather than getting too much in the weeds about, you know, what someone did or didn't do, or what someone did well or didn't do well. But if let's say it's something with an error or something where there maybe was a latent safety threat, then that would be another conversation that we would have to have. But we don't really do any sort of, what we're trying to do is just, Carrie, if you want to jump in here.
Yeah, no, I would say that it just wouldn't happen within the debrief. So the person that brought that concern forward, it would be a one-on-one conversation with the facilitator after the debrief, and then a conversation with management about next steps.
And then Stuart has a few kind of quick answer questions here. So I'll just there's three of them. So I'll just say them all at once. So number one, is this interprofessional? Two,
Yeah.
how many are taking place per month? And three, who pays for the training?
So I will answer for Children's Minnesota. It is becoming interdisciplinary. We started with nursing, but we have had respiratory therapy now join some of our classes. So we're hoping other disciplines will soon follow. Who pays for it? Currently, it's paid out of the budget, the education budget from each unit. And Justin, I forgot the other question.
About how many per month are you guys doing?
So Suzanne and I don't do any of them. And so it's difficult for us to always have a good number. But from what we hear word of mouth and some of the forms that we have back, we're probably having 2 to 3 a month.
Okay. Joe, Trish, do you have a sense of how many you guys do?
Yeah, so we always ensure that the meetings are multidisciplinary, but sometimes in the ward areas it can be really difficult when they don't have the doctors that would be in the units. And we get our patient at risk nurses to attend as well where they can if they're not involved in the ongoing care. Sometimes in the emergency department we even get the pre-hospital carers, the ambulance staff to come, and some of the OR staff, the operating room staff will come as well. I'm trying to pull up some data as we speak about the numbers that we would have in a month, and we really only kept that data for the first 10 months, and then we decided that it didn't hold much purpose in us collecting that data. And I think the frequency was slow as we did a really soft rollout, and it took us a little while to get training across all areas in child health. And so it became, it grew as the rollout occurred. The payment for who does the training and that sort of thing is really interesting. Oh, hang on. During the, I've got the data for the amount of documented ACE reviews per month, and it looks like it increased through the rollout to probably about 10 per month within the first 6 months of that happening, and that was the documented event reviews. As far as the training and who would provide that, it was agreed that the simulation program would develop the program and roll it out and train people, and from there it was grandparented on for people to do that. We actually also developed a handy little guide, just a leaflet for people who were facilitating it if there had been an interval since they'd last attended one or done some training as well, so we gave them some resources. And then staff did that and attended in their downtime, because we brought the teaching to the clinical environment, and just people were taken away for some time during their day to attend training, or else we embedded it in other education programs. So if staff from the PICU were doing a senior nursing day, we'd have a 20-30 minute presentation on ACE review.
Justin, could I just clarify one thing? I
Yes.
think I misinterpreted the question. As far as interdisciplinary, the debrief itself is interdisciplinary. So anyone who was hands-on with the patient or the patient's family, staff-wise, is invited to attend. So doctors, nurses, social work, child life specialists, any therapy groups, they would be invited to join.
Great, thank you. There's a couple just kind of comments that I think are worth mentioning, just because they're pretty poignant, and I think we would all agree with them. So Mark Hatt says, I believe it's amazing to do the clarification for staff post-critical incident. Lots might understand, but many of us leave inventing our own story of what we could have done, and it's an easy rabbit hole to fall into. And I think I very much agree, and it just speaks to the idea of frames, and we all have our own experiences that we bring to things and create our own stories going forward. And then Stuart makes another comment. As we go forward, I wonder about all the different terms we are using for this process. I think we need a common definition for the process, and wonder if, quote, clinical event debriefing, quote, may cover most of what we do. When you publish, please include the terms clinical event debriefing so it comes up on a search. And then what's the average time for debriefings?
So Starship was 12 minutes.
We don't really keep track of time, but I would say 15 to 20 max.
Yeah, so we recorded for the first, as Trish said, the first 10 months. We asked for people to send their forms back to us so we could have an idea of how often they were being used and what sort of was happening during the conversations. The average time was 12. The range was 5 to 35. And so those ones that were taking particularly long, when we looked at those, were often taking place further apart from the time. And we found that using it in CRM since, we've also increased the time because of that as well. But I think it's interesting to see what this sort of creep with the format that we created with the purpose of having an immediately post-event discussion being used at times a day or 2 days later as a structured format, because people didn't have a format to debrief the event in a conversation that felt safe. And so that's, I think, where the longer duration has crept in, having looked at the time from event to debrief.
And then next comment from Kelly McNaughton from Toronto Sick Kids. She's a program manager in peer support and trauma response. I spent 25 years doing trauma response to first responders and trained in CISM, NOVA, and I apologize, I don't know what those acronyms are for, but Road to Mental Readiness, etc. We have a trauma response program offered throughout the hospital, and I follow the CISM model aligned with children's approach. I think the skepticism about CISM is concern for vicarious trauma. But if you have qualified mental health specialists facilitating, they should be managing the process discussion. There's no treading into quote unquote detail. I've not had experience though where people delve into detail and as most are sensitive towards colleagues and adding to their trauma, so they err on the side of discretion. I think that's an interesting point about potentially treading lightly, not to add to the trauma. And Mark has another question. Do you believe this program impacts facilities financially in regards to reduced sick time, stress leaves, etc., or in regards to increased time for senior management with reduced unit visits for staff conflicts?
Interesting question.
Yeah, I think that's something that Carrie and I have tried to, we would like to do some more exploration to see if this is really impactful in that way. And Carrie, I'll let you finish talking.
Well, we have a newly established committee on workplace wellness, and we are trying to gather more metrics around, what is the impact not only of distress debriefing, but other wellness programs at Children's. Are we seeing less sick time? Are we seeing people not jump around as much, which would help with our education costs? So I think more to come on that. We don't have that information just yet, but want it.
And then last question, again from Kelly. Have either groups looked at blending the medical and psychological debriefs? A blend of the models would be ideal, but navigation could be perhaps difficult. Someone needs to come up with a model.
Yeah, I would love to do that. Ideally, yes.
And I think that one of the reasons that the four of us got together so passionately is that although we're doing very different things, we actually think both are really important. And we, in Starship Children's, found ourselves very much directed away from the emotional. It still comes in, and we still see there's a huge value. And in fact, the feedback that we continually get is that it provides emotional support. So I think there's definitely an opportunity to increase the emotion within ours and to look at a blended model.
I agree wholeheartedly, as I think too, it is important to talk about human reactions to an incident, but it's also equally important to talk about the clinical aspects and to unpack that as well. So I see that they have equal value. And so I think the challenge to us is how do we take this a step further and blend something that works, that could be applied in clinical debriefing events that accommodates both of those things and allows for people to process fully what they've experienced.
One of the most powerful statements for me in our feedback that we did at the start of this year was from one participant and supported by similar comments from a second person who said that clarifying the medical facts prevented me ruminating at 3 o'clock in the morning. And I thought, gosh, that simple, just making sure everybody's on the same page and understood what happened with the patient really prevented that middle of the night fear of what did I do wrong? What did I do to cause that to happen? I think there's huge power in just preventing that.
And I also want to add that although, you know, we haven't taught our teams how to do that safe emotional debriefing, you know, we're not psychologists and we don't have psychologists available 24/7. We did put a bit in our guide that to normalize people's emotional responses. So it's normal to be upset after these events, and just some framing words so that it was recognized and not just sort of this big elephant in the room, so that if people did say those things, it was led by the person who was facilitating the meeting, that it's normal to be upset or to be confused or to have concerns after these events. This is why we come together, just to see if we can get everybody on the same page and explore what happened.
Yes, I think that's a very important point. I think even though maybe you're not directly doing that, I think what people need to hear is what they're experiencing is normal, that they're having a normal reaction to an abnormal event.
And I think especially to what we normalize at a children's hospital, what becomes our norms, it's important to remember that it's still not normal and it's still impactful and still hard. Even though we signed up for this, we knew what we were getting into maybe, and we want to be there. It's so important to find a way to support people that want to be there and that are really good at their job, even though this job can be really demanding and taxing in lots of different ways sometimes.
I very much agree with that statement. So on that note, I will we'll wrap up. So thank you everyone for your questions, and thank you again for the lovely presentation. And just some quick closing comments here. For the people who joined us today, be on the lookout for an email from IPSS that will include a link to an evaluation, and we are very thankful for you to take the time and complete that survey. And the recording of today's webinar, along with the handouts, will be posted on the IPSS website in the near future. We hope you will join us for future webinars as we continue to expand and schedule and present more hopefully useful information. And then one last thing, as the co-chair for IPSSW 2020, we are getting close to making a fairly large announcement, so please be on the lookout in your email for that as well in the next coming weeks. So thank you all again, and enjoy your day/evening.